Welcome to SDHC's Health and Wellbeing podcast. Before we begin, we want to emphasise that the information shared in this podcast is for educational and informational purposes only. While we strive to provide accurate and up-to-date content, it is not a substitute for professional medical advice, diagnosis or treatment. Always seek the guidance of your doctor or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. Remember, your health and well-being are invaluable, so prioritise consulting with a medical professional for your personalised care. Hi everybody, you're listening to the Health and Wellbeing podcast from Hillbrow Health and Wellbeing and SDHC with your host, Dr. Nick Harvey. The purpose of this show is to help people understand how they can help themselves and others with their health and well-being. Every episode I interview an everyday expert to understand the latest evidence and advice on how to improve your own health and help others. We're delighted to have Khalid Malik here on the podcast, orthopaedic hip and knee specialist with a well-established practice in East Sussex. Khalid splits his time between NHS at Eastbourne District General Hospital and Conquest Hospital and his private practice at Nuffield Health, Brighton Hospital and Sussex Premier Health. Khalid's expertise spans a wide range of procedures including extremity trauma, primary total hip and knee replacements, unicompartmental knee replacements, robotic-assisted and custom joint replacements, and revision surgeries for both hips and knees. He obtained his medical degree from Imperial College London, one of the world's leading medical schools. After completing his specialty training across Kent, Surrey and Sussex, Khalid refined his skills through a specialist fellowship at the renowned Wrightington Hospital, a centre famed for its pioneering contributions to lower limb arthroplasty. Khalid now performs between 300 and 400 joint replacements every year, combining traditional expertise with modern technology. Khalid's practice is characterised by outstanding patient feedback, with his work recognised in 2024 when he was awarded the I Want Great Care Certificate of Excellence. He continues to innovate within his field, always seeking to improve surgical practices and contribute to the development of future orthopaedic professionals. Driven by a passion for his work, he's committed to sharing his knowledge and expertise with the next generation of orthopaedic surgeons. Wow, Khalid, welcome.
Thank you very much for the warm welcome. Glad to be here and great to meet you.
Yeah, great to have you here. I'm exhausted listening to everything you do, even on an annual basis. I mean, 300 or 400 joint replacements a year. That's a huge number, isn't it?
It is a reasonable number, but it just keeps life quite interesting because I do hip and knee replacements. So my practice is sort of split in 50-50. And that means that doing 300 to 400 joints a year gives me the ability to be able to do 150 to 200 joints on the knee side and the hip side. So it keeps the volume up, keeps the expertise. And really, we know that high surgical volume leads, generally speaking, to better patient outcomes. And it just keeps you busy, and busy is good. I enjoy doing what I do, and I'm happy to be able to provide these services to the communities across East Sussex.
Great. Before we came on, we were talking a little bit about family as well as our own health and how we keep ourselves fit. With you so busy in your professional life, are you managing to, support your personal life? Especially you mentioned about your own knee problems and how you support that, because I think that can often help all of us, really, isn't it? Keep well and fit. So give us a little window on that.
So I'm probably not the best person to talk about work-life balance. I personally don't think a perfect work-life balance really exists. I think it is a myth, but I think striving to achieve that is definitely something we all should continue doing. From a personal perspective, I think I tend to sort of divide my preferences into three sections. I've got my family, my practice, and my health. Really, I think I try to just achieve the perfect balance between the three. And I try to be flexible, I try to be organized. And in order for me to strike that balance such that, one of these aspects of my life don't just fall apart, I ensure that I'm organized. I've got a great team around me. I've got great colleagues who can step in at times. I've got an excellent secretary who ensures that my schedule is well balanced. And whenever I sort of see that there's potential conflict or where I see that I'm needed more at home, I adjust my practice accordingly. I think on top of all of this, I'm also very much aware that my own health is very important. I had an ACL injury when I was 23. I ended up requiring an ACL reconstruction, also had meniscectomies due to the damage in my knee. I knew quite a long time ago that, 10, 15 years down the line, I will start to pay the price for doing all the sports and sustaining all the injuries. And therefore, I noted myself that if I've not worked out, if I've not taken the time out to go to the gym, do the low impact exercises, engage in the strength and conditioning work, then I myself start to suffer from pain in my own knee, which inadvertently makes me quite unhappy. It makes standing quite difficult if you're operating. And therefore, I'm constantly ensuring that I am giving enough time to all three aspects of my life. Having a happy wife means a happy life. Having happy kids makes us happy. Having, a busy practice, having patients that are satisfied makes us feel great about what we do. And working with colleagues that are excellent who help you out also just keeps the momentum going. I think, as I alluded to earlier, I just think perfect work-life balance doesn't exist. I think there has to be some flexibility all the time, and one has to remain organized and stay on top of things, really.
Thank you. And interested how you really utilize those around you to support you to maintain that. Thank you for that little window. So, talking about little windows, then we're talking about surgery and minimally invasive surgery earlier on. I'm interested to touch first on kind of robotic assisted surgery, because it's something that you practice. Tell me a bit more about that.
So robotic assisted hip and knee replacement surgery is not something very, very new. We know that the robotic technology for both hip and knee joint replacements has been around for well over a decade, but it's really just the last 5-6 years that it's really taken off. And the principles behind performing these procedures and why this has really come about is, historically, we have relied on certain things, which to this day applies, such as seeing the patient, examine them clinically, ensuring that we do x-rays, which are really 2D views of a 3D structure, then planning the operation accordingly and essentially executing the surgical steps in a fashion such that, the patient achieves a stable joint with good range of movement at the end. But in the olden days, and even to an extent even now, we heavily rely on 2D imaging of a 3D structure, and really x-rays are 20th century investigations, and we are now in the 21st century. We know no two patients are the same, no two knees, no two hips are the same. So each person has got an individualized anatomy, which is specific to them. And what robotic surgery really allows us to do, there really are sort of two main steps. One is surgical preparation and surgical planning. And what that normally involves, once we have seen the patient and agree that the patient actually requires a hip or a knee replacement surgery to, treat their pain and optimize their function, we obtain CT scan. So CT scan provides us with a 3D model of their hip or their knee, depending on what joint we're doing. And it gives us very valuable information. We can clearly see what the deformity is, what the anatomy is, and what is it that we're trying to achieve surgically. So using that 3D template, we can then plan where are we going to place our implant. For example, in hip replacement, we can plan where we're going to position the cup, how much bone needs to be taken away to be able to safely seat the implants, how are we going to restore the leg length to ensure that the leg length is accurate, how are we going to ensure the offset, which is the distance between the shaft of the femur and the center of the rotation of the hip, how are we going to restore all of these biomechanical markers to ensure that patients have the best possible outcome, because optimal implant alignment is associated with implant wear. It is associated with patient function. So that's on the hip side. And on the knee side, we can use that 3D model. We can on a 3D model, we can plan where we're going to make our cuts, where we're going to put our implants, and how we're going to balance the knee. Now, that's the pre-operative planning side of things. When the patient actually goes onto the operating table, we've done all the planning, we've done all the thinking, and it's not just us who's done it. We also have our robotic specialists who look at all these images and ensure that the implants we're using, the sizes we're using, they do fit our surgical plan. And then on the day of surgery, once we've opened the knee or the hip, we tend to then register the patient's bony anatomy, ensure that what we're finding within surgery aligns with what we've got on the scan. Once we've registered the hip or the knee, then the robotic arm comes in, which is mounted on top of a robotic machine, all in a very sterile fashion. And within the very set parameters that we've established prior to surgery, we will then do the bone removal or we'll use a saw, or we use a reamer to prepare the bone surfaces to the millimeter accuracy that we had planned before. And once we've done that, we will then put the trial implants and ensure that actually what we set out to achieve prior to surgery is what we've achieved on table. And even if there is a millimeter inaccuracy there, we can adjust for that, redo some of the bone cuts, and give the perfect result that we know we can give the patient. And it's really us as surgeons leveraging our previous skills, surgical expertise, and using a robotic-assisted tool as an expert surgical assistance to achieve what we call the most accurate possible hip or knee replacement. And generally speaking, that's how a robotic-assisted joint replacement is performed. It's incredibly accurate. It is equally as invasive in my eyes as a routine non-robotic hip or knee replacement, because one has to open the knee or the hip to an extent where you can see all the relevant bony anatomy to be able to safely seat those implants. But the thing that makes it minimally invasive is that we do not take another millimeter of extra bone in order for us to put the implant in, which preserves bony anatomy, which optimizes the alignment of the components that are put in, which can potentially in the long term reduce any extra wear of the implant. And we try to give the patients the most physiological, the most natural feeling hip or knee replacement. And that in a nutshell is robotic assisted joint replacement.
Fantastic. Really high tech. And I don't think it would take much convincing to understand that this is, the most accurate way. How does that translate into customer satisfaction, as it were?
So this is an interesting question. A lot of the studies that are coming out now, they are focusing on patient satisfaction. So anecdotally, we heard that patients, they experience less pain. They report that their joints feel a bit more natural, but this was anecdotal. And in medicine, we like to do everything using the evidence base. We've had several papers that have come out of the high volume robotic centre, certainly in London. So University College London was one of the first few hospitals that had one, maybe more robots available to do these operations. And what we found in those research papers were that the complication rates were similar or less than the typical conventional joint replacement surgeries. We found that the level of pain reported by patients was lower. We looked at the PROMS data. I'm not taking credit for it. We as the orthopaedic community looked at the PROMS data, and we found that the earlier PROM data was more encouraging with joint replacement surgery. Now, what will probably occur in 10 years, 15 years time, only time will tell. We now know that there's a randomized clinical trial, which is the highest level of research evidence that's coming out, which is looking at all the clinical as well as functional outcomes. And we will soon find out the answer to that. But generally speaking, from my experience, I do both. So I do conventional joint replacements, I do robotic joint replacements. And what I tend to get, really, my experience has been that in knee replacement surgery, it gives you a very natural feeling knee. When you bend your knee, when you straighten your knee fully, how the knee feels, how stable it feels, it tends to just feel very, very, very natural with robotic assisted joint replacements. With hip replacement surgery, because of the accuracy of the implants being placed in, I know with 100% degree of certainty that I've restored the leg length and that I've put the components exactly where I plan to put them. So I'm hoping that in the long term, the data will show that we're just that bit more accurate. Whether that will mean there will be a substantial increase in patient-reported outcome data, I think time will tell.
Sure. So we think also it probably will lead to longer-lasting replacements, but don't know for sure.
We don't know for sure. So far, we use the National Joint Registry as sort of the main source of data, which informs us about implant longevity. And some of the proven implants we are using, we know that they are surviving over 90% in 15 years time. So actually the survival data of proven implants is already very good. But we've only really started putting high volume or relatively high volume of joint replacements using robotic assistance in the last 5-10 years. So we won't know their sort of survivorship outcome data up until the next 10-15 years time. So
And if I'm a patient, what's my choice here then? Because obviously you do both. And what is the reason? Because of access to the robotics, or?
I think the latter. So access to the robot is the main thing. There are high volume NHS centres in the UK that have a robot available. For example, places in Scotland, there's definitely Golden Jubilee Hospital that I know that have a robot. We've got University College London that has it, Exeter have it. So there's not that many hospitals that have bought the robot, as it were. I think in Sussex, the SOTC, which is associated with the Royal Sussex County Hospital, they have a robot, but this is not something that's available to all NHS hospitals. So yes, to an extent, it does depend where your referral has been triaged to. So if you are in a, hospital that doesn't have access to it, there isn't really a choice. But then when we look at my practice, for example, so I practice enough in Brighton where we see both NHS patients, we see private patients, and when patients come in, they either come in asking for, robotic-assisted joint replacement, or when we've seen them, spoken to them, we've decided upon progressing with surgery, then we discuss both options. And we give both options to the patients. We give them a fairly unbiased view based on what the research evidence is currently. And if they would like to go ahead with the robotic-assisted joint replacement surgery, we would do that. And if not, then we will do the conventional joint replacement surgery. And one thing to clarify is the implants that we use for that, the conventional versus robotic, they are the same implants. It's about where we're making those cuts and where we're placing the implants.
Mm-hmm, mm-hmm. Thanks for indulging me on that. We could talk forever. It's a fascinating subject and it's only going to get more and more developed, isn't it? I think in the coming decade. We touched on the phrase minimally invasive surgery, slightly ambiguous phrase, isn't it? Do you want to expand on that and what expectations are around that and what expectations should be around that phrase?
So I think there are two aspects of minimally invasive surgery. I think we've got to think about this in terms of joint replacement separately and arthroscopy separately. So arthroscopy is the procedure around the hip or the knee, which we perform using 2, maybe 3 very small stab incisions, normally no more than a few millimeters long. And then we go in with a camera and some equipment to perform the operation that's required. Now, there's no doubt that arthroscopic surgery is better than open surgery for one particular pathology. So in the knee, for example, if one is doing an ACL reconstruction or when they're doing a meniscectomy, arthroscopic surgery, which is minimally invasive, has been proven to be much better than open operation. And that seems to be now the gold standard of treatment. So there's no debate about that. Now, in my specialty, which is more around joint replacement surgery for the hip and the knee, I think the minimally invasive surgery could be slightly misleading term. Some people may define minimally invasive surgery as a procedure performed via a very small incision, whereas there's another concept where you make an appropriately sized incision to view the joint that you're replacing, and you're minimizing the internal dissection to try sparing most of the tendons around the hip, for example, to try accessing the hip. So there's definitely two schools of thoughts. I think I like to use the philosophy of appropriately invasive joint replacement surgery. So if you've got a large patient who's got significant, soft tissue envelope around their hip, for example, or if you've got a really muscly person who's got lots and lots of muscle bulk around their hip, then one trying to do joint replacement through very small incision may well lead to certain risks, such as, inadequate view of the joint, potential fractures, excessive retraction of the soft tissue. So it can actually lead to more harm than good. And that's something that's worth considering. Whereas minimally invasive surgery for somebody who's, older age group has got much more flexible, pliable skin, quite slim, and we can access the hip or the knee pretty quickly, then doing small incisions, minimizing internal dissection is all entirely feasible. So yes, I think if we are preserving soft tissue, we are doing adequately sized incisions, we're minimizing the amount of retraction, then patients are then more likely to recover much quicker. And they tend to get on their feet much quicker. They tend to have really good outcomes. And those settings, minimally invasive surgery is incredibly successful. And we see that day in, day out in our practice. Whereas in patients who are really rather quite large, whether it's adipose fatty tissue or whether it's lots of muscle, one has to actually then make appropriately sized incisions and one has to do a properly sized dissection to expose the joint and put the implants exactly where a surgeon means to put them.
So thank you. So we're really kind of highlighting that patients probably want to ask more about, what is the best way of approaching my problem with the highest chance of the best possible outcomes, rather than, can I go minimally invasive? Because it doesn't really translate necessarily to the right outcome.
Absolutely. I think patients that come into clinic with a certain expectation, without having been seen, without being examined, without having had their x-rays done, without having those conversations, I think one can be led to believe that one particular procedure is better than the other. But it really is after that assessment, after that conversation, after finding, appropriate information, evidence-based information, that patients can be more informed about which approach is better for that particular patient. So it's individualized decision-making, individualized surgery for that one particular individual.
We come across this time and time again in medicine, isn't it? There are an infinite number of ways people differ in terms of their symptoms, their anatomy and everything, and their expectations after. And there's so much value in just centering it on them, isn't it? And the benefit of all that knowledge. And on that note, I'm really interested in what feels like maybe the next big fad or something more significant in orthopaedic surgery, which is customised implants, isn't it? You can expand on that for me?
So customised implants is something that I was exposed to certainly in my fellowship. So when I went for my subspecialist training, we used a significant number of customised implants. And at that stage, we were doing customised implants as part of a clinical trial. We were comparing them to sort of the standard implants rather, to see, which ones will go on to have better outcomes. So the data from that is pending. But, it is something that's extremely valuable. It is certainly cutting edge. There's definitely place for it especially in hip and knee joint replacement surgery. Now, there are specific indications. There's specific reasons why customized implants can be used and should be used. So as we alluded to earlier, no two patients are the same. So vast majority of the patients, they fall within a normal distribution. So they may be slightly taller, they might be slightly bigger, both in terms of their hip, their knee. They may have slightly varied anatomy, but most patients fall in the subset of patients where standard off-the-shelf implants made by several orthopedic companies, the implants will fit as long as the cuts are being made appropriately and that their knees or their hips are sized appropriately. But there are a small number of patients that have very much altered anatomy. So patients that are born with certain problems, so congenital hip issues, patients that have had trauma, so fractures around their bone, their hip or their knee, which causes bony deformities. They may have infections that cause for example, the femoral canal to be completely occluded. In those kind of cases, standard off-the-shelf implants may not be suitable because the equipment we normally use to size the hips or prepare from the bony surfaces may not work. And when we see patients and we've assessed them, we've done appropriate imaging, we can anticipate that. And in those cases, actually, we have the availability of this technology where we can get, again, CT scans, 3D models, and then based on the results and the analysis of their bony deformities, we can ask certain companies to make customized implants, which are essentially a copy of what patient's natural anatomy is like, an implant that's made specifically for that patient. And with those implants, we tend to get patient-specific instruments where we don't have to sort of use our conventional instruments to prepare the bony surfaces. And through that combination of CT scan, CT planning, customized implants, and patient-specific instruments, we can achieve a successful joint replacement surgery for a patient with quite a significant deformity and altered anatomy. And there's definitely place for it. I think customized implants as a standard across the board for all patients, I'm definitely not a proponent for this because it's certainly not necessary. The data that we have for hip replacements, knee replacements for standard implants is so good that why make a good operation, potentially more complicated, absolutely. But on the other hand, patients that have significant bony abnormalities, we know that the data that we have in customized implants for the last 10 years actually shows quite successful outcomes. And generally those patients tend to be the younger patients who've had significant issues. For example, I had a patient who was only 19. We had to do a joint replacement on that 19-year-old patient because he had sickle cell disease. Because of sickle cell disease, he had this condition called avascular necrosis, which caused for lack of blood supply to the femoral head, which caused the femoral head to completely collapse. The anatomy was all over the place. And in order for us to even consider doing a joint replacement, we had to get a CT scan, and we had to analyze using the standard implants, see whether this was even feasible to do with the standard implants. And when the answer was no, we contacted one of our companies that we had a contract with and asked them whether they could help us. And within a matter of a month or so, we managed to get the CT scan, got the implants made in Germany, and they all came in a box with the implant, the patient-specific instruments. The operation was no longer than the routine operation. The patient had a really successful operation. I think the patient is now a few years down the line and doing really well. So there is definitely a place for it. And when it works really well.
Mm-hmm. Thank you. Yeah, fascinating. So a lot of people who might be listening think, all very good, but this is quite cutting edge. There's probably a lot more generalized tips that we can come up with. And before we do that, are there any other kind of common myths and conceptions that we haven't touched on yet that you'd like to share?
I think that there are a few. I think that first, the misconceptions. So patients, over a certain age, when they start experiencing hip pain, one of the most common misconceptions and that I tend to encounter in my clinic is that patients coming in saying, I've got pain in my hip, and they've got their hand on their side of the hip around the buttock. That's really one of the most common misconceptions. And patients feel that just because they're over a certain age, whether it's 50, 55 or 60, and they've got pain on the side of their hip, that undoubtedly they've got arthritis because their parents did. So it must be that. That's definitely the first misconception. And generally speaking, what I tend to inform patients that actually the normal telltale signs of arthritis in your hip tends to be pain in your groin. It may radiate to the buttock. It is possible that you may get some associated pain on the outside part of your hip, but generally speaking, it's groin pain, stiffness, inability to bend down, tying your shoes. Those are really the telltale signs. And actually pain on the side of the hip tends to be something else, such as bursitis, which is inflammation of the tissue on the side of your hip, or possible tendinopathy of the muscles attaching to the side of the hips. So that's something I encounter quite regularly. I think some patients coming in with knee pain and then being entirely convinced that pain is coming from their knee, when in fact the problem is higher up. So that's the other thing that I speak to patients about regularly. And therefore in my practice, I ensure that when I see patients, I examine both their hip and their knee to ensure we're not missing any pathology. Those are really the top two. The third one that I encounter a lot, certainly in the Southeast Coast, I think we all love walking. Everybody walks. And although we encourage walking, I think one must not get confused between walking and exercising. So when we ask the question to patients, do you exercise? They say, yeah, I'll go for long walks. And actually, going for long walks when you may potentially have an arthritic joint isn't really the best form of exercise, because you're essentially loading the joint without having to really engage the muscles around that joint that stabilizes the joint, that offloads the weight around it, that helps redistribute that weight. So actually, yes, walking is great. It's a great aerobic exercise. It has a lot of mental health benefits, but it's not necessarily the best form. And actually, what my advice tends to be for those patients, yes, do continue to walk, but actually you need to engage more in the stretches, the strength conditioning work, the boring gym exercises, putting on those repetitive movements regularly 2-3 times a day are really the things you will benefit from more. So those are 3 misconceptions, really. I think the myths, the other thing that I would very much like to talk about is, when is the right age to have a joint replacement operation? I think there's most commonly question asked in my clinical practice. I think we're increasingly seeing patients in their 50s, maybe even 40s, who've got significant hip or knee arthritis. And rightly, some patients feel that actually they're too young to undergo joint replacement surgery. But sometimes I get that odd patient in their 40s or their 50s who has significant debilitating arthritis of their hip. And anybody who's listening to this, anybody that has experienced significant arthritis of their hip, can probably recall how miserable it was. Really, every single movement from sitting, standing, lying down, working, driving, life starts to become quite difficult. And in fact, people tend to start limiting themselves to their home, their neighborhood, just to their shopping mall. They don't go out for walks. And I think if you're finding yourself in that situation and you are young, if you have established arthritis, this myth that, I'm too young for a joint replacement surgery because if I have a joint replacement now, in 10 years' time, it will have to be redone. It, to an extent, is true, but actually, I think there's a bit more to this story. As we talked earlier, that the implant performance of the most up-to-date implants that we have used over the last 20 years show that vast majority of proven implants over, the 15-year data is suggesting actually over 90% of those implants are working well to this day. So actually, if the indication is correct, if the reason we're doing the joint replacement is correct, we will most likely improve your function. We will most likely treat your pain. You're less likely to have complication. A hip replacement has been deemed as the operation of the century. So actually, if you're living in your 40s with miserable degree of pain, I think one has to look at that option. And all the surgery, I'm not a huge proponent of doing surgery when it's not required, but there are instances where that myth can actually hinder patients from seeking that help. In those instances, I would say do see your doctor, do see an orthopaedic surgeon. It's worth getting that looked into. It's worth investigating. And together we can talk about whether a joint replacement surgery is the right option for you.
Mm-hmm. Thank you. And in that young group, it's devastating, isn't it? What sort of outcomes would you expect? So I'm just thinking of, say, a 50-year-old who wants to go skiing again.
Very good question. You should expect to be able to do the things you were doing 1 or 2 years before you started to experience pain in your joint. So if you're an expert skier, let's say a year before you started to get debilitating knee pain, you're conditioned to do that activity. Your quadriceps, your glute muscles, your calf muscles, your lower back is conditioned to do that. Once you've decided to undergo an operation, if you do have a successful operation, if your knee replacement has been done well, for example, you're most likely to be able to regain that level of activity, that level of independence. That's obviously slightly different to somebody who's not done any exercise for 5 years and has come and had a joint replacement. I think it's very difficult to get that patient back to doing something they did maybe 10 years ago. But for somebody who's been doing this consistently up until a point, and they've had significant pain and discomfort from that joint which stopped them from doing something they love, they all tend to return. I've certainly had patients that have gone back to dancing, skiing, playing golf, cricket, and really knee or hip. They have all done that. Yes, the recovery is long, it's difficult, it's tiresome. You need incredible degree of mental resilience. You need good strength and conditioning coaching after surgery. One has to be sensible, and one has to acknowledge that actually all improvement tends to occur in small incremental doses. I think giving yourself a set timeline saying, I will return to skiing within a matter of 3 months, is probably unrealistic. But I think one can go back to walking, then potentially jogging, then afterwards training for that sports-specific activity. There's no reason why you can't return to your pre-morbid level of activity status.
That's an amazing thing for people to hear, and underlines probably the importance, would you not say, that the importance that if you've got a severe arthritis, to have the operation before you decondition over many years?
I would definitely agree with that. If you've got known arthritis, if you are to continue leaving things just because you're waiting for, let's say, retirement, or you're waiting for some other life event, or you're waiting for something to become debilitatingly painful, that probably isn't the wisest approach. I think at that stage, if you start to experience loss of muscle bulk, what we call muscle atrophy, loss of conditioning, generally speaking, we all tend to have some degree of deterioration in our overall health, which means we have less physiological reserve to be able to withstand the trauma of surgery. Then you're most likely to then have a slightly poorer outcome. You will still benefit from an operation, whether you're having it done now 5 years or 10 years. But I think what you then get at the end of that post-operative recovery is something that you can't really quite determine what it would be like in 10 years time. So if you have significant arthritis now and you and your surgeon have decided it's the right thing to do, then it's worth not waiting. Now, that being said, if you had significant arthritis and pain when you saw your surgeon, and over the course of the next 2-3 months, for some particular reason, your pain just improved and you got better and you're doing things you enjoy doing, don't just have surgery because you've had an agreement. I have seen that once or twice when patients actually came back and said, well, after our last chat, I went and started, going to the gym, started swimming, and my knee pain has gone away and I'd like to see whether I can wait. And those instances, I say, yes, please do. I think if you started to put some minor lifestyle changes that has resulted in improvement of your pain and function, and you improve your muscle bulk, there's no reason to undergo an operation just because we've had that discussion.
That highlights something really important, I think, doesn't it? In that we have been talking about severe arthritis, but that can be classified on an X-ray, for example. But we're really talking about the coexistence of that with significant reduction in function, usually because of pain, I would say.
Yeah, absolutely. I think when we look into the psychology and biology of pain, I think it's quite clear that not all pain in a knee or a hip comes from the joint, the cartilage surface, or the bones alone. A lot of the pain is also associated with what's happening to the muscles and the tendons around that joint. So although you may have arthritis, and the arthritis might be quite clearly visible on the X-ray, if you have no pain, you probably are somebody who's compensated greatly because you just sort of stayed fit all your life. And in those instances, I certainly would advise against undergoing any form of operation unless you really are experiencing, pain, stiffness, and impact on your quality of life. And at the same time, if you've gone and seen a surgeon and you identified to have some changes on your X-rays, don't wait for this to continue deteriorating and then end up having a joint replacement. I think the point of contact, once you've seen your GP, your first contact physician, physio or orthopedic surgeon, at that point, once it's decided, actually, let's potentially go down the surgical route, you need to, I think, familiarize yourself with the concept of prehabilitation, which is before any given surgery, you've got to treat the date of surgery as the date of a marathon, for example, and then train for it. We know the amount of trauma that your body goes through during surgery is equivalent to running half a marathon or a full marathon. So why not train for that? So going away, you have a few months, maybe a year, in some trusts 2 years waiting list to undergo a joint replacement. Why not go engage in low impact exercises, go see a physiotherapist, go join a fitness class, do low impact exercises such as stationary exercise, bike, swimming, gym-based work, low weight, high number of reps, and it will start to become abundantly clear to you what the health benefits of that are. You will reduce your level of pain before surgery. You will stop your reliance on taking significant amount of painkillers, which will give us a better baseline to work with before surgery. And you will make yourself fit enough to withstand the rigors and the trauma of undergoing an anesthetic of either form. And then once you actually have your operation, you will get up on your feet and you will get back to your normal life a lot quicker than if you were to not do those things.
Fantastic. So you've answered my next question, which was about preparing for surgery. Maybe we need to talk outside of this room then about getting your patients here to Hillbrow for the months leading up to their surgery. Is that, is there anything structured in place at the moment, or is it more just your advice? And
so up until before COVID, I was an orthopedic trainee. And I remember that when we used to list patients for surgery, they used to go to something called joint school or bone school. And it used to be a group meeting, normally led by somebody who has expertise in post-operative or pre-operative recovery. And they will inform patients about what they're going to have done, what exercises they can do, and what resources there are available. I currently do not know of any organized program where patients can go and get in touch, familiarize themselves with a group of people who are about to have an operation and go through this prehabilitative program. But it's certainly something that we are increasingly seeing the value of. It's definitely something I think we need to put in place. I think the burden of hip and knee replacement surgery is becoming abundantly clear. And actually, even for one bad outcome, I think it costs the NHS thousands and thousands of pounds. And it may well be incredibly cost effective to put these preventative measures in place to negate the likelihood of a negative outcome for any of these patients.
Fantastic. Okay. Let's make sure we keep in touch on that then.
Absolutely.
So is there anything else that you haven't touched on yet in terms of how best people can prepare for surgery and ensure it's successful after?
So preparation for surgery. So it's different stages, really. I think the first stage, I would say, for patients is to gather as much information as possible and get credible information. So we have lots and lots of online resources available, such as Versus Arthritis. We have the NHS website. We have websites of East Sussex Healthcare NHS Trusts with information around what joint replacement surgery is. So the first thing really is for patients to try understanding what is it that they're suffering from? What is it that they're planning to have done? What are the benefits? What are the risks? And what the associated recovery looks like. Just having a map roughly in patients' head to navigate their way through is incredibly important, okay? And only that way one can make an informed decision and informed consent about surgery. So that's the first step. The second step, I think we've talked to length about, the importance of physical conditioning, weight loss. I think in addition to that, diet. We know diet plays an instrumental role in post-operative recovery. So a balanced diet, reduce calorific intake, but good quality calorific intake, ensuring plenty of fiber available. We know your diet does to an extent dictates the degree of inflammation that your body experiences after surgery. So there is definitely an element of having a balanced diet. Pain control. So vast majority of the patients who come see us in clinic who are being considered for joint replacement are on significant amount of painkillers. And I don't blame them. I think, you start to experience pain. The first thing you do, you take a paracetamol, you move up, you take ibuprofen, that doesn't work, and you carry on taking the higher level of pain medications. But I would advise those patients that if you're on a list to undergo joint replacement surgery, try getting yourself off all of those painkillers slowly, with the guidance of your physician, because you know that there's an endpoint to this pain. And in fact, you not being on painkillers prior to surgery makes the post-operative pain management a lot easier. And we have a much sort of predictive baseline that we can work with in terms of pain management. Certainly those three things. I think simple investment, like buying an exercise bike, a stationary exercise bike, it doesn't cost more than £100-200. I know, the current cost of living crisis is, it's a topic, but I think this is probably one of the best investments you will make. Do all of those things. And that's what I would do preoperatively. If you're a smoker, you need to quit smoking. I think myself and other surgeons around me are probably unlikely to offer joint replacement surgery if you are an active smoker. So that's something that has a significant association with high risk of complications. And other than that, look out for other resources available around you. I think I'd probably avoid a lot of TikTok and Instagram based videos, because as much as you can see a lot of the health benefits, you can also see a whole lot of people posting about the horrific complications, and complications do occur. Your surgeon will talk to you very clearly and openly about the potential complications that can occur and the percentage risk of all those complications. So you're better off having that conversation with a clinician, and certainly a clinician that is going to perform that operation. I think that's really all my top tips.
Thank you. I was just listening to you talk about diet, reminded me maybe a topic that's more related to the osteoarthritis than the joint replacement surgery, but we probably wouldn't do the topic justice without touching on glucosamine chondroitin, I wonder. And also just wondered on your thoughts around vitamin D deficiency, which we're seeing a lot of, and whether that could impact prostheses, successful prostheses and things.
Right. Okay, fine. So I'll talk, of course, I think if there's no osteoarthritis or there's no arthritis, there's no joint replacement. So they're both interlinked quite directly. So in terms of, the importance of glucosamine, chondroitin sulfate. So you're alluding to the supplementation that's available. Right. So I don't have a significant handle on any data that has shown a direct proportional relationship between consumption of these vitamins or supplementation and lack of development of arthritis. Yeah, I don't have handle on that data. I've tried looking for it, and I don't think we have any published direct clinical studies that have proven any causation between, prevention of arthritis and taking those supplementation. But on the other hand, one thing that's quite certain and that's quite clear to me is patients that ask me that question and who are already on the supplementation, I don't discourage them from using this. And there's only one simple reason for that. Generally speaking, if a patient has looked after their health to the point they have looked at all other options such as supplementation, that group of patients is a self-selective group of patients that really deeply care about their own health. So they're not only eating well and exercising, they are taking those supplements. So undoubtedly that group of patients are most likely to be those that are going to have good health outcomes, whether that's related to the fact that they've taken those supplementation or purely because they've put all other measures in place that optimizes their health. And that is what I tend to see, really, certainly in my practice. And therefore, I wouldn't go to lengths to say that, yes, you must have their supplementation and there's a direct effect. But then at the same time, wouldn't discourage it. We haven't come across any studies to suggest that there's an actual harm causation from these medications, supplementation. So that's one side. The other side is the vitamin D. Osteoporosis, osteoarthritis. Again, very common question being asked. We lack significant degree of sunshine in the UK. Well, I know we're in the Sunshine Coast, but if, every day is like today, then there's no sun here. So undoubtedly, we know that over half of the UK population is deficient in vitamin D. That certainly has a correlation with your bone health overall. In terms of your joint health, it's not directly related to having joint issues, because your joints, they're separate anatomical structures. Okay, the makeup is slightly different. The factors that drive joint pain or joint wear are slightly different. But that being said, vitamin D has a very clear correlation between pain and how pain thresholds work. So patients, generally speaking, who are vitamin D deficient may actually experience more pain from minimal degree of arthritis, and that's certainly something that needs to be looked into. I think the second thing is if you've got significant degree of osteoporosis, which is related to vitamin D and calcium and your overall bone density, then the implants that we tend to use, certainly for hip replacements, we tend to use cemented implants, because when we are inserting those implants, we are really using a pretty heavy hammer to impact those implants on. And if we are doing that with soft bone, we can create fractures. So therefore, we tend to then use cemented implants. So yes, your bone health does determine what implants we use and our surgical strategy.
Thank you. And just to underline for listeners, so there's no confusion, the tricky thing with vitamin D is that it is deficient in so many people that the guidance is there to take supplementation from October to April anyway. And I wouldn't be racing for a test because our vitamin D levels fluctuate. And so a test in one point in time is usually not that helpful. Obviously, it can be really low and there are other signs of that. So talk to your doctor if you're in doubt, but I wouldn't just routinely ask for one.
Absolutely. I 100% agree with that.
So the last question was from Saul Rajab, ophthalmologist, and it really touches on, I think I know the answer now, having listened to you, how people who are highly active, elite athletes even, so Andy Murray, how on earth could he play tennis to that level on a hip replacement?
It's a very good question. It's, of course, a question that's come time and time again since Andy Murray returned to elite tennis after his hip resurfacing. And I think this is where the confusion is for majority of the public. There is a big difference between hip replacement surgery and hip resurfacing. And hip resurfacing, that concept was popularized a couple of decades ago. So late 90s, early 2000s, we tried to find a way where we can replace a joint or resurface a joint, try minimizing the amount of bone that's taken away to put an implant in patients with arthritis. That gives them better range of movement, reduces the risk of dislocation and reduces the risk of wear of the implant. And that's where the hip resurfacing concept was popularized. What Andy Murray has in his hip is a hip resurfacing. It's a metal-on-metal hip resurfacing, which was performed by a very eminent surgeon in London, Sarah Moorhead, in 2018. And that's a vastly different procedure to what we are performing in our general public and what is being performed in over 95% of the cases in the UK. And there's reasons behind it. Yeah, I think the first thing is for patients to try understanding is that this is not an appropriate procedure for vast majority of patients. The reason why hip resurfacing fell out of favor in the UK, in the 2000s, we performed a lot of those resurfacing procedures. And over time, over the subsequent 10 years, we saw a lot of patients that had significant metal debris that was generated in their hips. And that created a whole load of bone loss, adverse soft tissue reactions, and we had to revise large number of those procedures. It was a multi-million lawsuit. So there's a lot of issues around it, and therefore that procedure completely fell out of favor. But then the subsequent years, when we sub-analyzed in which patients did those procedures actually work, we identified young males with large femoral heads who were incredibly athletic and strong. Those procedures worked, and they had less wear. They didn't have no wear, but they had a lot less wear. They had a lot less metal ion levels. And we managed to, over the course of the last 2 decades, we managed to actually find that patient cohort in which this procedure would potentially be applicable. So, for example, in the US, there's a basketball player that had a hip resurfacing and returned to elite basketball. Andy Murray is another person that's had a hip resurfacing and returned to elite sports. So the first thing is that he had a different kind of procedure, which is performed by a very small number of surgeons in the UK, because they tend to have sort of the larger volume, and we all tend to refer to one particular person that does a large volume of that particular procedure. So combining that with Andy Murray's mental resilience, high level of athletic activity prior to surgery. I think we all know how many Grand Slams he's been a finalist of. How many did he win? How many did he lose? He definitely won 3, and he lost a lot more. And he became an incredibly resilient, strong athlete. And mentally, he was somebody who was willing to go through anything to be able to achieve what he needs to achieve. And I think that, combined with his prehabilitation, post-op focused rehabilitation, he has an excellent medical team around him. He has access to physiotherapy 24/7, state-of-the-art equipment. He would have had all sorts of assessments regarding his gait analysis prior to, after surgery. He would undoubtedly be tested for metal ion levels to ensure that he's not having any metal ion debris in his hip. I'm certain that he would be having, routine x-rays. So he's returned to tennis due to a combination of excellent surgery, excellent mindset, excellent prehabilitation, excellent post-rehab, and specific exercises for him to return to that tennis sport that he loves dearly. But sadly, that is not the case for vast majority of the population. And therefore, it is not the procedure that I think we should be proponents of for all patients. There's a very small sub-selection of those patients that are suitable for that.
Thank you for that really thorough answer. It's fascinating and interesting. I didn't realise the extrapolation from the metal on metal hip and how that evolved and the evidence involved in that group of patients. Thanks for all your insights. It's been really good. I know that we're going to follow things up around how we improve prehabilitation and rehabilitation in orthopaedic patients. I think there's something quite exciting that we can do together. Thank you for your time, and I'm sure our guests will join me in thanking you for giving us all those pearls of wisdom.
You're welcome. Thank you for having me, and thanks for giving me this platform to be able to talk about things that I love talking about. Thank you.
You've been listening to the Health and Wellbeing podcast, where today's focus was on innovations in hip and knee replacement surgery with Khalid Malik and me, Dr. Nick Harvey. For more information and resources, check out our website, sdhc.org.uk. If you have any feedback or suggestions for future episodes, please email us at sdhc.feedback@nhs.net.